Hi, everyone. Welcome to the VBC One Take Studio. Really excited to have Wynda Clayton in studio today. She is Director of Risk Adjustment, Coding, and Compliance with RAAPID. And considering all the discussion that there's been and concern around RADV audits, I couldn't think of a more timely guest to have in studio to interview. Hi, Wynda. How are you?
I'm fine. Thank you, Shannon. How are you?
Awesome. Doing well today.
Good.
Really excited to sit down and talk with you. I thought maybe we could just start off with a little bit about who you are. I don't know how anyone couldn't know you. I've known you for a long time now and see you around the conference circuit and speaking, and always have the greatest respect and esteem for your knowledge and experience, and always feel like I learn so much when I get to listen to you. And so I'd love to have our audience know a little bit more about you and get to meet you.
Perfect. Thank you, Shannon. Yes, my name is Wynda Clayton, and I have been around in the healthcare field for a very long time. I always say I'm telling my age when I start saying 30 years plus. I've been around. While I've been around in the healthcare industry for a long time, I've done a lot. I almost look at it as I've gone around the circle and I've come back. I've done a 360, but my experience includes that I've worked in a doctor's office. I've worked in compliance at a hospital. I've been a compliance officer. I've worked in billing as well as third-party billing. I've worked in doctor offices, and working in the doctor's office, I've actually ran their accounts receivable department. I've been a previous RADV auditor. Woo-hoo. I've also worked in a large health plan, and I've done that many years running the risk adjustment department. And then now I'm working on the vendor side. So I've done a lot, as you can tell. And then to mention, as you mentioned earlier, also being out there in the public and speaking in conferences and teaching. And I've also done provider education. So going out there, teaching the providers as well as what their documentation needs to look like.
So I couldn't think of a better person than to ask this question. And there's a lot of changes. There's a lot of, I think, uncertainty of what folks think is coming. We know some of it, right? We know that everyone is going to be audited, all 550 plans. Would love, as an industry expert, you just to talk about your thoughts on the changes that are taking place, and maybe any insights that you think that folks should be paying attention to. I know we're going to get in and we're going to talk in depth about RADV and RADV audits. And I love that you're a RADV auditor, because I think you're going to offer so much information to the audience. But let's take a moment just to reflect on, and we'd love to get your impressions again on what's going on in the space. What are you looking at and saying, hey, we need to be paying attention to that?
Yeah, absolutely. Like you said, everybody is aware CMS has made these huge changes. In my opinion, I expected it. It's not anything that's really a surprise. It's a surprise that it finally happened, because when we all know that when CMS says something's going to happen, it seems like it takes years. It takes forever for it to ever really happen. So now that we have that they are trying to play catch up again, I heard this years ago before COVID. I heard that CMS was going to eventually play catch up and try and catch up on all of these audits, where we should expect 2 to 3 audits a year. That was going to happen. This time, I think they're really going fast paced by saying we're going to have everything done by 2016. And we're talking September of 2016. Considering now we're looking at 6, 7 years that we're going to have to get done in order to have that completed by 2026 in September. But at the same time, again, like I said, it's not a surprise to me. I expected this to happen. Now, with all of the health plans being audited, that is more of a surprise. I didn't quite see that one coming. But again, with everything else happening, it's really not a surprise either if you really sit down and think about it with what's happening. At the same time, the health plans knew that this was going to come. At least they should have, people who've been around many years, because CMS has been out for blood. They've been out trying to say, hey, we've paid You've taken advantage of it. And because of you taking advantage of it, it's now time for us to recoup that money. Let's get some of the money back that we've given you that we should not have given you. So at the same time, I think it's good because I think it's going to make everybody think. It's going to put you on your feet. And it's going to make you say, okay, let's make sure everything that we're doing is ethical. Let's make sure we're doing it the right way. And I think that's what's important.
Thank you for that. I appreciate that. And it may be worthwhile. And if you want to define it, that would be fantastic. We have all different sorts of listeners in our audience. And so can you define for us or just tell us what a RADV audit is? And then maybe how that's different than other audits someone might encounter?
Yeah, absolutely. So RADV stands for Risk Adjustment Data Validation Audit. So the RADV audit, the difference there between where a person who may have not been in this business long or may have never encountered a RADV audit, you may have found yourself doing retrospective audits. Retrospective audits is done the year after the year of the date of services of when the visits have actually happened. And you do that, you're going through, you want to make sure that the claims that have been sent in from the provider are valid. You want to make sure that you have found all of those acceptable HCCs that you can find. The documentation supports it. And if you find additional, because we know that the providers get out there, they're doing their documentation, they may not always put every code on the claim. So this is also that time that you can get out there and say, okay, let's look through this documentation. Wait a minute, I see some conditions that are validated. They are supported within the documentation. Let's send this in because we're trying to tell the whole story of the patient. That's the key here when it comes down to risk adjustment itself, is we're trying to tell the story. What are the problems that this patient have? And in order to do that, all of their chronic conditions must be assessed. All of their chronic conditions must be brought out to say, this is the problem that the patient has, which in turn, this is what creates those RAF scores. And based off of the RAF scores, this is what CMS is then paying the health plans based off of, so that they can have that supplemental payment in order to pay the providers. I always tell everybody, keep in mind that the premiums that patients are paying, if they have a lot of chronic conditions, those premiums will never be able to pay for all of the visits that they have, their doctor visits, surgeries that they may have, prescription drugs. So that's why these supplemental payments come in, because it's going to allow the health plans to have that money. And if the health plans do it right, they shouldn't have to raise their premiums on these members year after year. They should be okay where they're not running into a deficit, and they can actually be able to say, thank you for doing your job, providers. We've paid you now to help your patients, our members. We can now keep the premiums where they are, because we know, especially when we start talking about the elderly, this hurts them to be able to raise these premiums year after year. Now, let's pivot over to the RADV audit. With a RADV audit, what is happening is CMS is saying, okay, you've paid these claims, you've sent me these extra conditions that may not have been allotted for originally. We've paid you these supplemental payments based off of the patient having a certain condition, or based off of the patient actually having this high RAF score. And based off of that information, we're paying you this extra supplemental payment. Now, what we want to do is make sure it's all right. So we're going to take a sample. We want you to give us a sample of all of your members, or we're going to pick a sample from your membership. We're going to send it out to you and tell you, now validate this. All of these HCCs you've sent to us, all of the HCCs we've paid you on, now we need you to validate it by sending us the chart note to prove that the patient really had this condition on the date of service, and not a matter of saying, I think, or it's a possibility. but we need you to validate that it was active on that date of service. So that's what you're going through during a RADV audit versus a retrospective audit.
And a couple of questions. I know, that as part of when the final rules came out, what was it, at the end of 24 now, I think, or 23? I don't even remember, time flies. But with extrapolation,
Right.
Maybe you could talk a little bit about that, about how that changes the game. Not that RADV isn't difficult enough, and I want to get into why it's difficult, right? Because if the patient saw the provider and it was documented in the data set, why isn't it there? What are the other things that we might be looking for? But we know the stakes are even higher. So not only are they auditing every plan now, but also there's that added piece that makes it different about how they're looking at data and the expectations around how you're documenting or making sure that certain conditions are documented.
Yeah, absolutely. That extrapolation is a big piece because now that they're extrapolating, and again, extrapolation is something that's been talked about for many years. ADV's been going on a long time. CMS has always said they were going to extrapolate, and it just never happened. But now with the extrapolations, one error can cost a health plan millions. Again, gosh, it's so imperative. I can't stress enough how imperative it is to make sure that you are doing this right, that you are viewing. I always used to tell people that the way CMS always looked at it was more or less of, before you pay that claim, you need to make sure that the documentation supports it. But we all know who has the bandwidth to be able to check every single claim that comes in when you have health plans that have lives of 150,000 for Medicare Advantage. Some have more than that, some have less. But again, who has the bandwidth to say every single claim that comes into your office, you need to make sure you're checking the documentation and make sure it's valid before you actually pay that claim. And if it's not valid, then okay, you send it back to the provider and say, I'm not paying this claim because I can't validate this particular condition that you put on here. We don't have time for that. But unfortunately, the health plans have got to figure out a way to make this work because, again, you don't know what that sample is. And even though it's a small sample, they've taken it and said, we're going from 35 to 200. 200 is still a small sample when you have 200,000 lives or you have 300,000 lives. That's small. It's not a whole lot. But at the same time, you don't know who it's going to be. And when you start looking at your sickest of the sickest members that you have, you need to make sure those conditions are documented properly by the provider. It's telling the real story of the patient. It's clear, it's concise. And now with even the change to V28, what has happened is that change is making everyone, the providers, the health plans, that those conditions that are being reported, that you have to have all of that information there. And I say that just as a quick example is saying, if you have that the patient has a condition and we need those labs, let's take CKD, for example, you need to have those labs to back it up. Don't just say the patient has CKD. And we need to know those stages because without that, you're probably not going to pass a RADV audit.
So many ways, so many places that I could go. And I think your experience, I'm excited to talk about RAPID, but I'm going to hold off for just a second.
Okay.
Would love to hear a little bit more about your experiences as a RADV auditor. Maybe there's some stories in there or things that you learned or experienced that folks out there that are listening could learn from as they're getting ready if they were to be called for an audit.
Yeah, I would say it's been a long time since I've been a RADV auditor. I was a RADV auditor almost when RADV audits first started. So I was on that beginning end. A lot still has not really changed. I still know people who do that job, friends from that I had when I was actually doing it, and I still keep in touch with them to know what's happening. But at the same time, you need to know is just prep yourself prior. Always be ready because you never know when that time's going to come that you're going to have to perform a RADV audit. One of the biggest things is now that we know that CMS is using AI, that's another part is that people need to realize that you need to play the game and you can't play the game by still using spreadsheets. I used it for many years. I know there's plenty of health plans out there that they perform their RADV audits by going through using spreadsheets. You're manually reading through every chart note, trying to find it. And that's great. That has made us all great coders. It has made us great auditors by doing that. But you've got to play the game. If they have apples, you need to have apples too. If they have oranges, you need oranges too. And by doing that means you may have to get into the AI game where you have not been in there previously. You're going to have to start automating things. But at the same time, you're going to have to make sure that whoever it is you're using, whatever it is that you're using, whatever tools, that you are sure you have tested it, you make sure that they know what they're doing, that it's accurate information that's being put out there. Because again, this financially can hurt. Those RADV audits can hurt a health plan. When one mistake can cost you millions of dollars, that's huge. You have a lot of health plans that will set themselves up where they have already started putting money aside to say, I'm planning for this to happen. But how many hits can you take? Especially when you're looking at right now that CMS is getting ready to look at 6 years. Can you take a hit like that every year? Can you take millions of dollars that you have to pay out every year because of the errors? I don't think anybody can. So with that being said, you've got to prepare now. Prepare for the future, as well as do what you can and make sure that whoever it is that's performing these RADV audits are experienced coders, not just coders, but that they have been in risk adjustment for years. Because again, somebody who just started out 1 or 2 years ago, they're not going to know the keys that of what they need to do to be able to pass that RADV audit. Again, it's not the same as a retrospective. What they're doing with retrospective is not the same way you're looking at your documentation to be able to turn that in to make sure it's valid, to be able to pass that RADV audit.
I think that's a really important distinction because I think a lot of folks don't recognize that. I know you talked a little bit about that before. Anything else that you would add there that folks should be looking for when they're looking to validate on a RADV audit, what they need to find within the record?
Yeah, again, active. The condition had to be active on the date of the encounter. You want to make sure you have those proofs. Make sure you have the labs. Make sure you have x-rays. Make whatever it is that you can find that proves that it was active on that date of service. That's actually the key.
Question for you. What if it's within the calendar year that the data service would fall for the reimbursement? So say the patient came in on February 2nd and then came in again on March 1st, and the March 1st claim was called for review and it didn't have the evidence that was necessary, but the February 4th one or 2nd one did, the early encounter did. Would that be okay? Would you be able to successfully argue your case that it was a legitimate submission, or does it actually have to be that specific date of service?
That's a good point, Shannon. I'm glad you brought that out. One of the things, so I'm gonna back up a little bit. When you get that enrollee list from CMS for the RADV audit, that enrollee list is going to list the patient's names as well as their date of birth and their HICN number. And then it's also going to give the list of HCCs that have been submitted to CMS. and the diagnosis codes that are associated with that HCC. Again, that's been submitted to CMS. It is for the entire calendar year. So if you're working on 2018, 2019 dates of services, it's going to be for that entire year. Now, you could have that possibility that on one that may have actually been submitted on the claim is not the chart note that you're finding that will validate that HCC perfectly. If that's the case, don't worry about it. You can go to another date of service within that calendar year. And if you can find documentation that actually supports that HCC, that's what you want to submit. And it may even be a different ICD-10 code that associates with that HCC than the ICD-10 codes that CMS listed on your enrollee list that was previously submitted. And if that's the case, it's fine. That's what you want to use. So that works for CMS. Now, how long is it going to work? I don't know, because I do expect that CMS is going to come back soon one day and say, if that wasn't submitted, we're not going to accept it. But for now, you can get away with that. So yes, keep an eye out for that.
I just bring that up because I remember working for a risk-bearing provider group. We had audits, and the health plan that was auditing us gave us specific dates of service, but we were able to identify the condition. I don't remember why there was something that was off at the time. I think it was like had to do with like claim flag, or there was something, but we were able to validate that the code was legitimate for that patient. And so in that way, we were able to stave off having any clawbacks of revenue that was shared with us because of the risk that was submitted on that patient. But it was interesting because I think a lot of groups don't recognize that. And if you're not thinking about that, that's important. But I would agree with you. Looking at what's coming out from CMMI and the talk about encounters and data and the accuracy of that, I definitely think that in our very near future, that's going to be important, and everything is going to have to be tied up and linked to one another.
Yeah.
Real quick, I wanted to ask you, just to make sure that we drive the point home, you had mentioned they've said that they're going to do these things, and it almost seems like an insurmountable task, right? They're going to rapidly go through these many years of data. They're going to look at these 550 plans. Everyone's going to be audited. I know that they're hiring people, but even having people, right, is not enough. And you mentioned AI, and I think that makes it possible. Could you talk a little bit about, for those that might be saying, oh, we've got time, they won't get that done, those naysayers that don't think it's coming. Could you talk a little bit about the realness of that? And I know you're on the insides of technology, and we're going to talk about what RAAPID's doing here in a second to help with that, with your leadership and your input. But talk to those people that think, oh, it's not going to happen. They'll never get it done.
And that is so true. And I've been hearing that, and everybody is saying, there's no way. How are they going to do it? They'll never get 6 years done by next year. And again, AI is going to be the key. That's what's going to help them. Even though they're talking about hiring up to 200 coders, keep in mind that if you're using AI and AI is pulling it out for them, it's going to save them a lot of time. As a RADV auditor, I can remember going through, and it was always it's very strict. We would go through, and we still had so many we had to get done within a day, in being able to work in a day. So many we had to audit, but accuracy was imperative. If you could not meet the accuracy, if you could not meet the quantity and being able to get that many done, you ran a risk of losing your job. When I ran at a risk adjustment department at the health plan, I made sure my coders knew that it was imperative that we worked and that the accuracy of your coding had to be at 98%. People always said 98%, that's high. CMS doesn't require 98%. You've got to keep in mind, you've got to be better. And that was the thing when I was a RADV auditor. We had 98% accuracy. That's what made me come up with the 98% accuracy when I ran my own risk adjustment department. because again, I needed to make sure that as they were seeing 95, I need to be a little bit better. If I'm better, then I have a better chance that when something gets pulled, that I don't have to worry about whether or not it's accurate and whether or not we're going to be able to pass that RADV audit. So that was always my key. And that's what I worked on, was looking at that. But is this going to happen? It's going to happen. So folks, as you sit here thinking it's not going to, there's no way they're not going to do it, they will make it happen. You may not have your results back soon, but the RADV audits will happen. And trust me, when they say this, that it's going to happen and this is what they're determining that they're going to do, I would not step back and say, hey, we don't have nothing to worry about. We got plenty of time. I wouldn't bank on it. Even if they don't get all 6 years done, I would expect that at least 4 of those years will probably get done. So beware.
And I love the mantra. I'm going to adopt that. We must be better. So I love that.
Yes.
That's we like the title from the episode. Must be better. Excellent. So you have been working with RAPID AI for a while, and I have been so impressed looking at the tool, what it has to offer. And you guys have actually worked on a tool specifically to help with RADV audits. I know I've had an opportunity to see a lot of the products and solutions that RAPID has, and I've been so impressed with the thought behind the technology that they're coming up with. It really makes sense, and it's things that I think that risk-bearing provider group health plans need and would find beneficial. And I'm sure that's in part a lot due to having experts like yourself to help inform the development process. And I know that you guys have a tool specifically developed to prepare groups for RADV. And so I would love for you to talk a little bit more about that. What went into that, the design of that, some things maybe that you're particularly proud of, maybe even some use cases of some of the partners that you're working with that you're finding that the solution is helping folks be successful.
Thank you, Shannon. I am really excited about this RADV tool that RAPID has put together. One of the things I'm going to start out with is that this RADV tool was made by RADV auditors for RADV auditors, which I think that just tells it all. It tells a lot about this tool. Again, we're looking at, I was a RADV auditor, knowing what needs to get into this, also knowing that I have ran a risk adjustment department at a health plan. I know what the health plans are going through as well. I know exactly what they need, what they're looking for in order to be successful in a RADV audit. Not to mention, we all know that they have crunched the time for those RADV audits. It's gone from that 24 weeks to now 12 weeks. And with that being said, how can we get this done quickly? But with this tool, this is what's going to help. There's actually 2 parts to the tool that we have put together here at RAPID. One of the parts to that tool is that it's a project management tool. And the good thing about this project management tool is that it helps with your workflow. So if you can put in your whole list that you've received from CMS, with that list, you have all your information right there at your fingertips, again, without having to use a spreadsheet. As you go out and you have to get your chase list so that you can chase after those chart notes, you can digest this into this workflow tool as well. So in the tool, now you have your whole enrollee list. You also have your chase list. You know exactly what provider for what dates of services you're going after to try and get the chart notes to validate, because also all of your HCCs and your diagnosis codes are listed right there in this tool. You can mark in this tool when you receive the chart notes. You can see what chart notes are still pending. You can also be able to say, hey, we need an attestation later on because we have a chart note that we received that did not have a signature or credentials were missing. And we can go ahead and say that's needed when that attestation comes in. You can mark that attestation as being received. So this tool is just fabulous to be able to go back and say, I can see everything. I know exactly where I am in this project. I know what's needed, what we haven't gotten, what's still outstanding, and it's going to help to bring it all together when working and performing these RADV audits. Then the second part of the tool is actually the audit part itself. So it's the AI audit solution. And with this AI audit solution, what this does is now this is your AI tool that's actually going to validate all of your HCCs. So this AI tool will allow the auditor to just say, go in and it's reviewing the chart note. It's going to pick out all of those. It knows exactly which HCCs that need to be validated. It's going to look to those HCCs to be able to validate those HCCs. If it cannot find the exact HCC to validate, it will also look for a lower or a higher HCC to be able to validate as well, because we all know that when it comes in, and if you don't know, let's put it that way, a key to submitting is you want to submit something. You should never not submit a chart note to CMS for a RADV audit. So whatever it is that's being audited, whatever member for whatever HCC, always make sure you submitted a chart note. Even if you don't think that chart note is the best chart note or that it's strong, you want to submit it. If that's all you have, that's what you've got to do. So with this AI tool, that's what's going to help you, because it's going to be able to say, hey, here's a strong one. Here's one that's not strong. It's going to allow for ranking. So you can say, okay, this is the best one. This one is not the best one, but it's still going to allow you to submit. And because CMS is only allowing 2 documentations per HCCs to be submitted, again, my suggestion is if you have 2, submit 2. If you only have 1, then okay, submit only that 1. But since they are giving you that 2, you want to go ahead and submit both.
I think that's so important. And agree with you. Why not? If they give you the opportunity to submit more, then submit more. What I love that you say the tool was created by RADV auditors for RADV auditors. And I had shared with you earlier, I think that technology that's backed in that way is important, right? Because you want to make sure that it's going to do the things. It's one thing to create something when you think, but when you're actually in the mix and you know what's required, I think that you're just able to inform that much better of the tool.
Absolutely.
What has been the response of some of the groups that are using your tool today?
The tool actually will be launched at Rise West, but those who have already seen the tool, they're excited. Everyone is excited to be able to say, yes, I have somewhere that I can put my information in. I don't have to worry about working off of a spreadsheet, making that mistake of putting it on the wrong line because you're working off of an Excel spreadsheet, but your information is right there. And because there's 2 parts to the tool, RAPID is allowing those health plans that if you don't want both parts, maybe you only want the workflow, you can get just the workflow tool. But if you want both, they can be integrated together as well, and they will work together, which is what my suggestion would be. I think it's great to have all of your spreadsheet information integrated in with being able to work with the tool to be able to validate those HCCs.
I'll put a plug in. I know more information will be coming out, but for those that are watching, there is going to be a scavenger hunt. And part of that scavenger hunt is booking a demo of this tool with the RAAPID team. And we are going to have a scavenger hunt for Rise West attendees, but even our listenership that can't make the conference have an opportunity to play along. And just know that one of those tasks that you need to check off in order to be a part of this contest is to book a demo for this tool with the RAPID AI team. And so you'll have an opportunity to see it too. Is there anything else that you wanted to talk about that I haven't asked about yet?
No, like I said, I think the biggest thing is just to let everybody know that, again, this tool, I'm excited about it. I think others will be excited about it as well, because again, everyone's working with critical times. So the time period is critical. You have very limited amount of people that you're working with. And what's happening is people are having to bring everybody in. You're having to throw the whole book at trying to complete these RADV audits just simply because you have a short amount of time. The biggest pain point is chasing the documents, trying to get those chart notes. And that's where the challenge is. Can you get the chart notes in a timely manner? It's not going to be as hard as it shouldn't be as hard trying to validate, but the question is, I need the chart note in order to validate. And how can I get those chart notes quickly?
And I know running even retrospective programs, how challenging that can be trying to get
Yes.
those timely. Even physician offices that are still open and regularly operating, they're so busy. And so trying to get those records in a timely manner can prove challenging.
Absolutely.
Wynda, can you walk us through what's changed in the RADV audit timeline and why it's such a big deal?
Yes. So what has changed is you now have a shorter amount of time in order to complete these RADV audits. We've gone from 24 weeks to 12 weeks. You can only submit 2 documentations per HCC, which once before it was 5, and now it's down to 2. Extrapolations, which we have not had to worry about that before, but the extrapolations are big. And I think the other big thing is just knowing that CMS is using AI, which they have not always used AI in the past.
Awesome. So you've worked all over as a RADV auditor. You've worked for a health plan. You've worked in medical offices. I think it would be great to get an understanding from you what the typical workflow that health plans follow now and where do they get bottlenecked,
Yeah.
especially knowing what's coming at them with this new RADV process.
So I think the typical workflow that a health plan follows is when they receive these notices that it's time for a RADV audit, you probably have a lot of them that are panicking. I got this notice. We're going to have to do this RADV audit. Who are we going to get to do the RADV audit? Because a lot of times they have not yet planned, but hopefully they do have that idea. They're planning now and they know who's going to perform the audits. The next thing is once you receive your enrollee list is having your analytic team put together a chase list. You need to know what claims have been submitted for these members for these particular HCCs and put together that chase list so you know where to start to go get the chart notes. And I say start because sometimes going back to what you had said earlier, Shannon, is sometimes you might find that you didn't even receive a claim, but in the documentation that the provider may have said, I sent this patient to go see doctor for this condition. And you don't see where a claim ever came in, but you may have to go after that doctor to say, hey, can I get your chart notes for this patient for this year? Get everything that you can. And sometimes that's the chart note that will validate the condition. Even though you don't have a claim for it, and like we said before, you can get away with that now on being able to submit that to CMS. But in the future, I don't expect that you'll be able to get away with it. Just like with ACA right now, you can't get away with it. Everything must have a claim in order to submit it to ACA. But where the bottleneck comes in is right there, looking for the chart notes, trying to get those chart notes in a timely manner, trying to get those providers to actually give you the chart notes as you're requesting it. The providers are busy. And with that being said, when you go and start asking them for chart notes, their thought is, we don't have time. I've even ran into problems where the provider may come back and say, we don't have that chart note, or we don't have anything for that patient. And I have to go back and say, I see here that you filed a claim for that patient. So if you filed a claim and we paid you for it, then maybe we need to request our money back. And then all of a sudden, bam, miraculously, that chart note appeared. So people need to keep in mind, you've got to do what you got to do to be able to get that. So don't let the providers just tell you, we don't have it. If you have a claim that you paid them for that, you need to use that against them to be able to say, we need to request a refund. If you don't have a claim, or if you don't have any chart notes for this patient, since you filed a claim, that means you must have filed this claim fraudulently because of the fact that you don't seem to have any chart notes for this patient. So don't let them get away with that. I just want to throw that out there. But at the same time, once they get those chart notes, now it's time for the review. Getting the review done to validate the chart note, and then that's another challenge. But like I said, the bottleneck, I think, is more of getting the chart notes and then submitting it to CMS.
I think back to what you said earlier about we must be better. Again, it's a nod to sometimes you're going to have to, when you think that the path isn't clear, there's a fence in the roadway or what have you, you might have to go around it, go over it, go under it, blow it up. So there might be extra steps that you need to take to go further to get the information that you need, and having as much time on your side. So I think taking out some of the time that you might have spent otherwise without using a tool like the RAAPID tool, that you'll have more time back to you so that you can exercise these extra steps in case you need them. Because like you said too, the stakes are just way too great with the recoupments that could possibly occur because of extrapolation, and so important. So thank you. How are health plans adapting or struggling with the 90-day mark?
So I think I just previously mentioned that one of the things that they're doing, they're struggling because of the fact of trying to get those chart notes. That makes it hard to meet that 90-day mark. Planning, they hadn't planned for it ahead of time. One of the things I've been mentioning here for the last few months, especially since these RADV audits have been hitting big, is letting people know that RADV is no longer just a compliance issue. And I know that was the way people looked at it before, but because of the extrapolation, you've got to remember that this is an issue for everyone. It's an issue for the board. It's no longer just compliance. From your C-suite all the way down to your coders, this should be important to everyone. And everyone needs to make sure that you're doing your part to make this happen, to make sure you're successful. Otherwise, it's going to cost you a lot.
What are the limitations of running RADV projects from spreadsheets?
I think when it comes down to running the RADV audits from spreadsheet, you have that limitation of that you could possibly miss something. So you're not going to possibly catch everything. It's also going to cause you more time, because as you're running it from that spreadsheet and you're going through and saying, okay, wait a minute, we found this condition. I'll mark this on the spreadsheet. Oh, wait a minute, this condition was not validated. Or wait a minute, did we get this chart note? Or where is the chart note at? There's just so much there that it is limiting you when you start running RADV projects from spreadsheets. And like I said, I know a lot of us have done that. You've done it for many years, and that's where you're at with it. But we've got to get out of that. It's time to say, hey, we don't have time based off of the time limitation to be able to run it from a spreadsheet any longer. It's now time to bring in automation and run it that way. Technology.
And I know the technology that you talked about, right, with RAAPID, that you have the ability to load your list and manage everything from there. And so that takes away that burden and that opportunity to transpose numbers or to potential waylay data, that it keeps everything organized for you.
Absolutely.
And for your teams.
Less errors.
Nice.
Yes.
Nice. That's important.
Exactly.
And want to give a nod that it's not just compliance, it's finance too.
Yeah.
I was audited once in the past and it was over 16 IPAs. And for each one, they were estimating to take back million and a half. So you could see that over 100,000 lives, it quickly escalated to over $16 million
Absolutely.
in clawbacks. And I just thinking what we've seen already that health plans have had to pay, and knowing that it's just going to be that much more, considering extrapolation, only having the two components, the two documents that you can submit for support, and all the other rules that are now part of the audit process.
It's funny, Shannon. I don't think people think about it, but this is definitely one of those times that it's for health plans who may have people out there that don't know, who have never been through a RADV audit, who have not had success in passing a RADV audit in the past. This is your time to reach out to someone who does know this, who knows about RADV audit. Get help, get suggestions, whatever it may be, because again, it's costly. And this is a lot of years that we're looking at. And you just gave a prime example, 100,000 lives, but yet you're talking about over $1 million.
Yeah.
So
16, right?
16. Oh, wow. Yeah, that's even worse.
Yes.
16 million with over 100 lives. And again, like I said, how are you going to sustain that type of hit?
Yeah.
And you look at 6 years of having, that's huge.
In your comment about reaching out, I think that's the one great thing about our industry too, is how close knit we are and how willing folks are to share information. So I'm hoping that they'll listen to this podcast, that they'll reach out to you, that they'll reach out to the RAAPID AI team to see how a solution such as yours may help them
Absolutely
get through these audits. What's one feature that you've seen your clients get most excited about?
the workflow, being able to not have to work off of spreadsheets and being able to use the workflow tool. I have seen them getting very excited about.
Exciting. Well, it's awesome because everything's there, right? In one place, and they can pick up the next day. And I think also too, when you have multiple people, I know in running teams in the past, when you have multiple people working on a project, because you have to, it just makes it very difficult to manage, and version control and all sorts of things can go awry when you're working off of spreadsheets. And this tool sounds great in that it's able to keep all of that together and allow you to bring your resources to work together to be most effective and efficient.
Yes.
Yeah. So one of the things, Wynda, that I know makes the RAAPID AI tool differentiated from others out there is that it has this neurosymbolic AI. Can you tell us, for those that may not know, what that is in plain English? Just explain what neurosymbolic AI is, and then why it would be important to be able to use in this RADV process.
Yes. So when it comes down to the neurosymbolic AI, look at it as more or less of it's an explainable AI. It's that next generation AI technology. And not only is it explainable, but it's also defensible. So what do I mean by that? When I say that it's explainable and defensible, I'm actually looking at with saying that this AI is able to pick up those conditions that another AI tool may not. We also have where those conditions that it's capturing are more, it's validated. In other words, we give justification. We tell you exactly why this is a condition that is validated within this chart. So that's where the explainable comes in, and also the defensible is because we're giving you the justification. We're telling you what the need is, whether it's been monitored, and what we find in the documentation that's monitored. It's evaluated. What is in the documentation that shows it's been evaluated? What in the documentation shows it's been assessed or addressed? And what in the documentation it shows it has been treated? So again, explainable, indefensible with this next generation AI technology.
Fantastic. How does evidence linking work and why is it important for compliance?
So the evidence linking works and it's important for compliance because with this evidence linking, we're saying we are giving you a condition, but we're not just pulling this condition out of the documentation just because we see that the words are there. The provider has documented that the patient has diabetes. Just because we see diabetes listed in the chart notes does not mean that the patient really has the diabetes. What we're looking for and what we have is we're saying we see that the patient has an A1C, and here's what the A1C is. Here we see that the provider has stated that the patient needs to have a better diet, or we see that the provider has actually explained everything necessary for this diabetes. He has the patient on treatment. Let's put the patient on metformin. Let's allow them to continue to take their metformin. All of this is the information that we have here, and this is where we're pulling this now. When it comes to the compliance of this, it's important just simply because you can't, just because it's there, we can't just say, hey, the patient has this condition. But we need some defense here. We need to be able to explain it. We need to be able to point it out in the documentation to prove that this condition was active. And not only are we proving it, but we're also being able to say, and we can support it. And so by proving it, we're supporting it.
Excellent. I know earlier we talked about, and again, I love that you said we have to be better and that you looked at 98% accuracy. I know working in the industry, oftentimes the number that's thrown out there is 95% accuracy. But we know that at some organizations, and I've been witness to this with some of the groups that we've worked with, that you can have accuracy rates as low as 40 to 60%. What does this mean for compliance?
Yeah, low accuracy rates like that, it's going to hurt. So when we start talking about compliance, you can't do it. And I know sometimes people think, no big deal, we'll get it corrected, we'll keep going. But it's hurting you more than it's helping you. But you've got to make sure that when your coders don't have that high accuracy rate, that work, you give it to somebody else and go back through it. That person needs to go back training. If they can't, and then once they go back through training, you need to give them just tests, part notes to be able to review. If they can't make accuracy, they've got to go because otherwise it's going to cost you more money than you want it to cost you just because of the fact that you're trying to hold on to a person or you're thinking it's not a big deal. Or what about even those that aren't even checking the accuracy of their coders? That hurts even more. Yes, compliant wise, it's not good. You should have that compliant program out there that's sitting out there that states compliance wise, everybody's accuracy must be at a certain accuracy rate. It needs to be checked on a regular basis, and they need to have that set up as well. How regular are you checking for the accuracy? Is it monthly? Is it quarterly? Hopefully it's not once a year because that's not enough. But we've definitely got to make sure that the accuracy rate is set there often.
We, in organizations that I've been a part of, and even now with my own company, BBC One, we will audit coders and we apply the rule that it's 100% for at least the first 100 records. And then thereafter, if they pass, then thereafter it's 10% of all records that they've coded to make sure, and would agree with you And there's opportunities for collaboration discussed because I think sometimes it's not necessarily black and white. Coding can be gray depending on what your rules are and what you've agreed to as an organization to follow. But agree with you, not only could you let codes through that shouldn't pass through, but you also run the risk of not submitting codes that should have been submitted, and then you're not getting that recoupment.
I look at it as in that hurts the members more than it hurts the health plan. Because again, going back to that health plan is going to raise those premiums for that member, and that's going to hurt them.
Why is flexibility so important in RADV solutions?
But flexibility is important because number one, you don't have everyone working the same. You mentioned that earlier, even when you said you have gray areas and everybody doesn't look at everything the same. And I think even throughout this whole podcast, as we've been talking, we've proven that the way one person or one health plan may work and do something, somebody else is going to do it a little bit differently. What they're looking for is going to be different, whether or not they have the amount of people within their department to do the work makes a difference. There's just so many parts. I think every piece of it that you look at, you have to have that flexibility in being able to perform those RADV audits, because without that flexibility, what one does, another may not. And that's the good thing about the RAPID tool, is that RAPID is willing to take this tool and set it up per person. Number one, even that flexibility of taking this tool, the workflow tool, and the project management workflow tool, and taking that and being able to digest in everybody's enrollee list. That's flexibility. If you have your coding guidelines, being able to take those coding guidelines and digest in your coding guidelines so that it's working based off of the way you set things up. Flexibility, again, important. So it's very important that in coding period, RADV or retros, it doesn't matter what you're doing. It's just important to make sure that flexibility is there.
I agree with you. I come across a lot of tools where, the largest health plan, that's the client of the tool, sets the rules.
Right.
And you might not agree with their coding guidelines.
Nope.
There may be things that you don't have an appetite for. And you should be able to determine what rules you're going to use or what components of the workflow are going to work best for your team.
Yeah.
So I love that and agree with you. Having been a leader in the operations space in this work now for more than 20 years,
Right.
25 years, flexibility is important because not everybody's needs are the same.
Agreed. And whereas we have the CMS guidelines, we have the AHA coding clinics, which we know everybody should be using. But some people do change things a little bit when it comes down to their own individual coding guidelines. So with that, you can digest those into it, and the coding of the tool and what the AI is reading is going to do it based off of your own internal coding guidelines as well. So I like that. And I think that flexibility is great, and everybody should be excited about that.
Absolutely.
Yeah.
How do you see deployment models evolving over the next few years?
So I think when it comes down to deploying this over the next few years, I think it's going to be, we're going to deploy a lot of them as these RADV audits happen more and more. And people are going to realize that they need an easier way to be able to deal with these RADV, whereas everyone is looking at it as how important it is. I want to do it myself. That's the good thing about this tool, about the AI audit tool, is that you can do it yourself, or you can have RAPID do it for you. We will also have those coders that are advanced and with my direction, knowing exactly how to perform a RADV audit. With that, either way, if you don't have the people to be able to perform the audit, we can perform the audit for you. Or if you have the stuff that you can perform it and you want to do it yourself, use the tool. The tool it will help you. It will minimize the stress, and it'll also save you some time.
We didn't really talk much about that. And I love that you have available coders because there are a lot of health plans out there and medical groups that don't have their own internal teams
Right.
or are limited, maybe not ready for RADV. Because, like you said, there's a difference between RADV and retrospective. Talk a little bit about that offering that you have as well, too.
Yeah, absolutely. So again, at Rapid, we have coders in-house that can actually perform those RADV audits for you. Whether it's retrospective audits, we can perform. We can also perform those RADV audits. So we're trying to make it simple for you. Not only are we saying, hey, we have the tool that you can put your own coders in, but like you said, for those who don't have their own coders, we have the staff here and we make sure we're performing the quality we do at the beginning before we even roll out any of the tools. We're doing the calibration. And with being able to do the calibration, we're going to digest some charts. We're going to check, make sure everything is working right, making sure that it's taking in all of your clients' guidelines as well as the CMS and the AHA coding clinics. We're going to make sure all of that is digest in. We're going to go through, review, make sure that everything is good before we start the audit itself. And once we perform all of the calibration, then again, like I said, if you are okay with it, and once we get the approval from the health plan, now we can have our coders or even your own coders can jump in and start the coding. Once that's all done, we will also provide you with output files. And those output files will give you the listing of what was found. And of course, when we're doing retro, we're looking both ways. So keep that in mind where we're doing the adding as well as the deleting. So we'll provide all of those retro files. But for RADV audits, we're going to provide you with that file to be able to say, here are the charts that we have found that validate. We're going to even put the naming convention on it for you, which that's another thing that's usually a pain for people is to have that naming convention all ready to go. But we're going to wrap it up in a pretty little bow is the way I look at it and present it to you so that all you have to do is fill out your cover sheet and go ahead and submit those RADV audits into CMS.
Fantastic. Couldn't be simpler than that. One of the things that I found as a leader is I'll look at a tool and then I find out that while it looks good on paper, it maybe doesn't work in the way that I expected or was thinking. How do you at Rapid prevent that from happening? Like, how do you control for that to make sure that the tool that you're demonstrating and what you're offering to the client and that they're getting, right, what it is that they expect?
Yeah, absolutely. So keeping in mind that our platform is built on an auditor's mindset. So not just coding. We're making sure that as we code, we codify the real world process. So again, we're not trying to just make something up. And that's where we come back with the made by auditors for auditors. We don't just show you a demo, but we prove it. For every new partner that we have, we actually start with the comprehensive onboarding, and then we also do the calibration process. We take that sample charts that I was talking about earlier, and we make sure that we use their own data, the data that we've received from that partner. This step will actually ensure that the customer is seeing the value before we actually go live. We want them to obey it. We want them to make sure that they can say, yes, I see this tool is doing exactly what you've said it's going to do, and we can prove it to them. That's what's being done.
Fantastic. And then I know Microsoft invested in your tool as well. Talk a little bit about how that helped bring this tool to market.
Yeah, so Microsoft, their investment has actually helped us. It's helped us in making sure that we build a highly compliant and secured as well as scalable tool. That's what they've done for us. They've also helped us to make sure that we're advancing our go to market where we can make sure we're being introduced to the right audience. And as long as we're being introduced to the right audience, it's helping us to be able to demonstrate the value of our solution. So that's where I think Microsoft has come in, and their investment has actually helped us.
Fantastic. How do you measure readiness before release?
So our solution is actually, it's technically validated for accuracy against those numerous data sets. We offer the policy management system, which you did hear me talk about that earlier, where I was saying the customer can actually have their guidelines ingested into the tool, along with the CMS guidelines that are already there and AHA coding clinics that are there. So by doing that, that makes sure that the rules that they want to be applied are the rules that are incorporated within an AI model before it's actually released to them. Then we can take that comprehensive customer, and we do the onboarding process, which is what I was talking about earlier when we were talking about the onboarding and actually doing the calibration. So we're going to do that with those sample charts before we go live.
Great. How can RADV audits actually improve coding teams as opposed to just checking the box?
The RADV audit is going to make a team better. And people may say, how do you figure that? Why do you think it's going to make them better? And I say that because with a RADV audit, you have to have a different mindset. The mindset can't just be, oh, I go through it, I validated this and it's there, it's there. It's going to make you think different because and I'm going to go back here to the retrospective versus a RADV. With the retrospective audit, you're going through and you're saying, okay, yes, I'm going to find new conditions, or wait a minute, I see that the provider put this condition on their claim, but as I go through and I review the chart, I can't find anything that actually validates it. So I'll delete that out. What happens with a RADV audit is, guess what? You're not adding codes, nor are you deleting. It's too late to do any deletions. So with that in mind, that means you have to defend what is already there. So what's already been submitted, it's now to put up bring your defensible hat out, put that on, and it's now time to defend. You don't want to go back and have a condition that you have to validate and say, I can't find anything to validate it. You need to come up with something. That means you've got to know your CMS official coding guidelines. You've got to know what's out there in AHA coding clinic, because you have to defend it. One of the things that I always used, even with my coders, is I said, when you're performing retrospective audits, I want you to think that anytime you go to enter a new condition, or even if you think that condition is validated before deleting it, is ask yourself, if I had to go before a court of law, can I defend this? If you can answer yes confidently that you can defend it, you're doing well. And I think that's the big thing, even when it comes to a RADV, is you have to be able to defend it. That's the mindset you have. Can I defend this in a court of law? So when you pull that chart note out and you're saying this chart note validates it, that means you can pull out solid evidence to be able to defend it, and not going off of, I think so, it sounds like, I feel like. Those words don't mean nothing. I always say, leave them where they are, because it does not matter to me. I don't care. I want solid answers. I want you to be able to pull out a guideline, a coding clinic. I need something that's solid that you can defend it.
I think that's an excellent differentiation and so important for our audience to hear. For those that don't realize or haven't been through a RADV, just what's at stake and what they need to do.
Yeah.
What happens when you integrate the tool into everyday coding workflows?
Oh, so when you take the tool, and are we talking more of the retrospective tool now versus the RADV tool?
Yeah. Yeah. How would we use this beyond you've gotten the RADV audit, how do you envision being able to integrate it into the everyday? Because I think even what you said before is it's not just about compliance any longer. It
Right.
touches everyone. And so how does it become ingrained in the work that you do, the culture, right? So that it's part of your everyday and that you're always thinking about even just what you said, that you feel that the codes that you're submitting are supported.
Yeah. So I think when it comes down to AI, just integrating this tool into your everyday workflow is going to be imperative because, again, accuracy, that's the key. We've got to make sure that everything that is being done, every code that is being captured, every deletion that's being done, it's all accurate. So to be able to apply an AI, and I'm going to go back to the neural symbolic, AI, being able to apply that type of tool and knowing that you don't have more false positives than positives that you have, it's important digest this in your everyday tool. You'll find that your coders can work faster. So their speed is going to pick up and they're going to be able to do more work than what they would normally be able to do, which will help you on being able to audit those chart notes more. Whereas earlier, when I was talking about saying nobody has the bandwidth to do, this is going to give them a little bit more where, okay, you don't have to have as many people, but you can still get more work done, more work with less people and be effective at it. Make sure it's efficient. So putting this in your everyday tool, everyday workflow, I think that's where it helps. And the stress is going to be less. Who's stressing over, oh my gosh, how is this right? How much? We're only QA 10% of the work that the coders are doing. What happens to the 90%, the other 90%? Maybe the 10% that's being QA'd isn't the ones where the errors are. So maybe we're not finding it. So all of this is what happens. And with our tool, you also have that QA process in there. So you have the QA in there. You can have several levels of people that are actually reviewing, which again, it speeds it up. So if you have one set of coders that review it, you can take your QA and do a second level, be able to review it. And even if you need to throw a third level in, third level can be done too. But I think it just makes that workflow, that daily workflow easier, less stressful, more accurate is what we're looking at.
And I would throw out there too, as a strategy, you can have people working to top of license. And so the team that you would normally have doing this work would be working when they're working with spreadsheets, would be able to do other things, work
Yes.
with your doctors on documentation, work on correcting encounters and making sure they get through. And so there's a lot of other options that you could put those resources to other work. And I think these are the types of strategies that are important when folks say, oh, V28, it changed things. It's the revenue and the recoupment is not the same. The reimbursement is not the same. Quality is a challenge. I'm not seeing the quality bonuses. Total cost of care continues to be a challenge. We're slightly behind on some of those programs. And so there's opportunities there. I think that this gives you an opportunity to not only reflect on resources and where you might better apply them, but then also too, you're saving money because you're able to apply them and potentially protect money because you're able to perform better in these programs or in these other areas that maybe you didn't have the resources for
Yeah.
in the past. So
Absolutely. Yeah, I
yeah,
totally agree
definitely.
with that. Yeah, and being able to have that, and like you said, embedding that into your workflow, it's gonna give even that educator that if extra information. It's going to give them the key of what they need to be able to take it back to the provider and be able to say, listen, let me help you with your documentation. Here's what you're not doing. Here's what we're finding on multiple records. And not only that, but maybe you don't have to wait so long. I always said when we performed retrospective audits and you wait until the year before, the year after, and then you're doing it all manually and doing it on paper, by the time you figure all of this out, you do your analysis, it's 2 years later when you're giving the provider information. How is that going to help him or her 2 years later? Maybe he or her they've already changed their way of doing things, their documentation. So it's better to give it to them more real time than waiting
Absolutely.
so late.
And also then less of an impact, right?
Yes,
Right? If you take forever to correct it, there's more instances of where
right.
things get way late as
Absolutely.
opposed to if you're proactive.
Absolutely.
And we know even in learning theory with adults that the more quickly you can correct things, the better. Because if you let bad learning continue, it becomes solidified and it's harder to undo.
Absolutely.
Yeah,
Absolutely.
definitely. Those are great
Yes.
benefits. I know that you're going live at Rise West, but I'm sure you have in your mind what you're expecting your clients and those that, partner with you to use your solution, the benefits that they're going to get from this. In your mind and from your experience, what's one quick win that you think that plans will readily experience after implementation?
Accurate coding. Being able to say immediately jumping into this tool and you don't have a lot of false positives, I think is a big win. I've worked on many tools before where there is a high false positive. So as you go through, you're looking and it's okay, wait a minute, it's picking up conditions from that it thinks it sees words in the address or in an area that we can't code from or whatever it may be. That's one thing you're going to find different. And I think that's going to be a quick win that I can say when it comes down to the RAPID tool.
How does your support model differ from what other vendors offer?
Our support model differs because the people who are going to get to you, we have experienced engineers. Not only do we have experienced engineers, but we also have experienced coders. We have that experienced RADV auditor from the past. We just have a lot of experience. We've been doing this a long time, along with being able to do transcription. Not only that, but when it comes to our tool, out of the box, our tool is giving you a high accuracy rate immediately, which differs from a lot of other vendors. So I think that is one of the keys. And that's something I want to point out is just being able to say your justification that's being given, the accuracy that you're going to receive is key. And you're not going to find a lot of false positives in our tool.
Why is a dedicated team important for RADV success?
Good question. A dedicated team is important because as long as the team is dedicated, they are they take it to heart. They want to make sure that this tool works for everyone. It works that the partner who is coming in and saying, Rapid, I want your tool. The dedicated team wants to make sure that they are happy. They want to make sure that they get everything that they need, that it works to their satisfaction. And this is important. I think it's important for anybody. And then when you have a problem, you can come to this dedicated team and say, listen, you did this, you did that, or I'm not seeing that it's doing this, and I thought it could do that. What do you do to help? Or explain to me why and what do I need to do different? We have that team, and everybody at Rapid is they're truly dedicated. They want to come in, they work day and night. I must say, I've never seen a team of people who work so much and so hard to make sure things are working and to make sure that the customer, that client, is also satisfied.
Fantastic. I know we, in this industry, we love the work that we do.
Yes.
For sure. What advice would you give to a health plan that's just starting with a new RADV tool?
Pay attention. So everything that we're giving you, just pay attention to it and use it to your benefit. I think as you take this tool and you embrace it, embrace using AI and be optimistic about what you're doing. It's going to make a big difference. And I think you'll find that once you actually get into it and start working it, you'll be happy. And try not. I think one of the things that even as people that we all do is when you've been working in other tools, you tend to always want to make a comparison. This RADV audit tool is something probably unlike anything you've ever worked in before. So try not to compare it to everything else. Think about what you want to accomplish. And based off of what you want to accomplish, let's make sure that the RADV tool is doing that. And I think you'll find that it will work to your benefit.
Wynda, I'll tell you, you won the award for being my longest interview.
Yes.
Well, we're almost like 2 hours.
And I had to hold myself back because when I start talking about RADV, retros, anything with risk adjustment, it's my passion. I'm so passionate about it.
I think that's fantastic, though. And don't hold yourself back. And then we'll do more. Hopefully, we'll do more of these too. Wynda, I think you've given us so much great information. And I really hope that there are folks out there that take the time to listen in to all the great advice that you have. And then again, also to reach out to you and get to know and at least demo the RAAPID tool. I definitely think it's worth seeing. Again, want to thank you and appreciate all the time that you've given us today and the knowledge that you shared with our audience. And thank you so much for being with us today.
Thank you. And thank you for having me, Shannon. I really enjoyed this. So I hope everybody out there listen, and I hope you get a lot of information from this. Thank you.
Likewise. Thank you.